Hi there, everyone. Let's jump into our conversation on the pathology of neuromuscular diseases. As you can see there from all of those abbreviations, we've got quite a few that we're going to cover. Let's start with Guillain-Barré syndrome. Okay, Guillain-Barré is an interesting condition in that it's a peripheral nervous system condition, which is autoimmune. In other words, the body attacks its own peripheral nerves. The nerves affected are typically motor, sensory, and autonomic, and this is at the level of the lower motor neuron. So it's from the lower motor neuron all the way out, right, if we're talking about the motor effects. The presentation, therefore, gives you progressive weakness of the limbs, and it tends to take out your DTRs. So those are often early signs and symptoms of the condition, and it makes sense with the description when you're considering the pathophysiology. Of note, the central nervous system is unaffected in Guillain-Barré. There are a lot of subtypes, and the most common type is called acute inflammatory demyelinating polyneuropathy, or AIDP, but we don't have to go into that. I'm just letting you know in case you see it in a chart. In terms of if you're already familiar with GBS, AIDP looks very similar, so that's typically what you'll see. Digging a little bit more into the etiology, this is kind of a strange one. It has a fairly iconic early kind of trigger for it. It's usually an initial mild illness, typically an upper respiratory infection, sometimes a GI infection. The person recovers from it, it's not of any note, and then a few weeks later, suddenly there's this rapidly, and I mean rapidly, on the order of hours, an evolving ascending weakness, some mild sensory loss, reflexes go down, and this process continues for approximately 4 weeks. When it hits its worst point, the technical term for that is nadir, N-A-D-I-R. So basically, at first, there's a weakness that they don't quite seem to understand, but it can go as quickly as walking around, typical mobility, to on a vent in like 36 hours. That's pretty aggressive, but it usually is very fast on the order of days. Etiology here, again, it's an autoimmune attack to the myelin of the peripheral nerves. Typical viral precedents, in other words, the bug that someone had before that they had GBS, are, of course, Epstein-Barr, CMV, and COVID. Also, sometimes you'll see it with AIDS. We're seeing a good few COVID cases these days. Also, sometimes the previous mild issue isn't as mild, it's more that they've had a recent surgery. To be honest, it's more commonly in clinic I've seen a mild respiratory illness or possibly a GI bug. So what actually happens? The immune system attacks the Schwann cells, and that's how you end up with demyelination. Thankfully, the axon itself is usually intact. It's the myelin that's damaged. And remyelination occurs quickly when that axon is unaffected. If it is damaged, then you have to go through Wallerian regeneration, and that takes a hot minute. That's the folks where it's going to be a longer course of recovery. So when you're considering all of these things together, a lot of what occurs is actually an autoimmune attack aggravated by complement aggravation, and that's how you end up with the nerve injury, especially if the macrophage gets in there and tries to clean things up. So take-home message is basically your body mistakenly starts to make antibodies that adhere to Schwann cells, causing an autoimmune attack. The antibodies were initially made due to a mild earlier illness, typically an upper respiratory infection. The autoimmune attack is therefore to the myelin covering, and you end up with eventual damage, possibly axonal damage. So who tends to get this? It's usually a disease of someone who's middle-aged. 40 is the average onset. It affects men slightly more than women, and the majority of cases occur after a mild infection. There appears to be no geography or preference otherwise. How do they look? This is a progressive weakness that goes symmetrically. In other words, both arms and both legs are affected at the same time, and it goes ascending. So it's usually lower extremities affected first, then upper extremities, then face, if that's going to be what they have. Not everybody has the face affected. Some do. There's often a severe radicular back pain or neuropathic pain in most cases, and sometimes we end up with diminished or absent reflexes as a result. The hyporeflexia being the result of injury to the peripheral lower motor neuron and its axon. Typically, there's not a whole lot of sensory loss, although there is some. If there is going to be sensory loss, it's usually what we call a glove and stocking distribution, which makes sense. Those are the sensory nerves which take care of the hands and feet, are the longest ones, so they're more susceptible to demyelination injury, demonstrating a deficit. You can have a little bit of demyelination and not show a whole lot of deficit, but the longer the nerve, the more likely that there's sites for the demyelination to occur and therefore the deficit to be obvious on clinical presentation. Cranial nerves are affected in approximately half the cases, and those are the folks where the face is going to be the last thing to show weakness, and this is going to be muscle weakness, which is a real issue when you're thinking about movement of the jaw and the tongue. Issues with the autonomic system are kind of common, unfortunately, and they tend to have a lot of issues with low blood pressure. In other words, sitting up can be very challenging between their back pain, their weakness, and their low blood pressure. It's usually kind of an event setting them up when they've been supine. So some patients progress quite mildly for several weeks, some progress quite rapidly and become ventilator dependent within hours or days. About a quarter of cases have respiratory failure, and those ones tend to do more poorly, which makes sense because sometimes you're fighting Guillain-Barré and respiratory issues such as pneumonia. Lab work on the workup on these patients tends to demonstrate increased proteins in the CSF, which makes sense given that this is an infection. I know the CSF is central nervous system territory, but it will still show that there's increased autoimmune sort of activity. And then on the more peripheral side of things, EMG or NCV will show the signs of demyelination and slowing. So to stop this process, they have one of two options. One is plasma exchange. The other is IVIG or intravenous immune globulin treatment. Both of these stop the formation of complement as well as just decrease immune activity. So with plasma exchange, they're removing those antibodies that the body has made against itself, as well as inflammatory mediators. And with IVIG, they're disrupting the formation of complement, which therefore globally decreases immune activity. Literature says they're both equally effective, but IVIG is more common and you'll see it more often. Of note, if you see this hanging on the IV pole, it's a beautiful amber gold color. And the joke always is that it's basically liquid gold, because it's more expensive per ounce than gold, which is fascinating. They do appear to be equally effective, but you can't do both. That doesn't seem to work. Okay, when we're talking about the course of Guillain-Barré, we can look at it in terms of its pattern of immune activity and in terms of what actually happens clinically. So what happens initially is the immune activity rises and then drops. And during that time, you actually have kind of like no issues, and then it tanks, okay? This point right here, which is usually at approximately 4 weeks, is the nadir. I'm going to put an N so that you remember that that low point, which usually happens at about 4-ish weeks, is the nadir. Then they start to get better. Why do they get better? Because remyelination is occurring, okay? So that takes a while, and that slowly starts to increase. So when they're in this stage right here, so as everything's dropping, until the point that they drop has one protocol of therapy. Once the nadir happens and the weakness stops progressing, then it will start to improve, and that's another phase of therapy, okay? So you have as we're heading to nadir and then after we've hit nadir. Prognosis. Most folks start to get better again at that 4-week mark. And then it takes a while. So the average time to complete your recovery is not quite a year, about 200 days. Some people do have some residual neurodeficit that's more or less permanent, but most people walk again and do really well. For such a serious condition, this actually does really well. If they do pass during it, it's usually due to complication, such as an infection. Think pneumonia. That's the classic one. So those are the ones who become vent dependent, which makes sense. So the negative prognosis factors include older age, which you don't have to be that much older for it to go poorly. If it happens really, really fast, in other words, if you go from not having a whole lot of issues to severe presentation in less than a week. If you need respiratory support in the form of ventilation. If you have really severe issues that demonstrate on NCV. Or if the initial illness was a diarrheal illness, such as C. jejuni or CMV that gets into the GI tract. One of the worst cases of Guillain-Barré that I've seen was a C. jejuni infection in an older male. Onset happened in about 5 days. He was late 50s, early 60s. He didn't get to a vent, but his muscles reached all the way down to about a 1 out of 5 on manual muscle testing. So he had limited recovery. I would say he only improved maybe 5 to 10%. So that was a severe case. Most of the time, though, they do walk again. That's the vast majority. And I've seen folks run again. In fact, I even had a patient once who had Guillain-Barré twice and I was treating them for the second infection, or the second round of Guillain-Barré, and he was going to walk again. So as severe as it can be, it actually goes quite well. So 6-ish months or 200 days thereabouts, vast majority of folks actually do a lot better. Let's switch to another diagnosis. This is also peripheral. So I'm going to put a big P so you remember it's peripheral. This is myasthenia gravis. It's an autoimmune attack at the neuromuscular junction specific to the acetylcholine receptors. We don't fully understand the etiology, but there appears to be involvement of the thymus. It's kind of strange. Because the neuromuscular junction is attacked, you have weakness of skeletal muscles. Makes sense given the etiology, and so the presentation will give you fatigue and strength issues. Who does this tend to affect? It actually kind of skews older males and younger females. I think the majority of cases that I've treated have been older males. I think I've had only 2 or 3 younger females with it. It's a challenge no matter what age you're at when this sets in. So weakness and fatigue occur with activity and improve with rest. That's classic, okay? So they want to rest all the time. They tend to do more poorly during the summer if they get an infection or they have high periods of stress. So for example, if they have something as simple as a sinus infection, they tend to have a lot greater weakness. Or if they're going through a stressful period in life, they tend to have a lot greater weakness, and then none of them do well in the summer. Notably, it does cause some cranial nerve issues, and that's often when it can get more dangerous. So how do they catch this? It's honestly, sometimes through presentation, in the classic, is weakness of the eye. Again, that's that cranial nerve weakness. Or sometimes they start to slur their speech or have difficulty swallowing, and those are a lot of times the early signs and symptoms. But the truth is, and again, this is a social determinant of health issue, sometimes it occurs in a younger woman, and therefore the symptoms are not taken seriously. And actually, the average time it takes to diagnose myasthenia gravis is upwards of 2 years. Yes, that's a very long time, and yet that's the truth of it. Once they actually take a patient seriously based on their presentation and complaints, they can do blood testing and detect very high levels of antibodies for acetylcholine receptors. They can give you a drug called idurfonium, which prevents the breakdown of acetylcholine and allows you to be able to see that, oh wait, all of those weakness issues suddenly disappear on the order of minutes. They can do a CT or MRI to look for issues with the thymus. They can check pulmonary function testing, and then they can actually check the health of the peripheral nerves. So here's an individual who's suspected for having myasthenia gravis. The weakness to her jaw is so great that she's forced to use her hands to keep her mouth closed. Once they give her myasthenia gravis, note that she's no longer having to hold her jaw, and she probably got so used to struggling to keep her eyes open that she's got that wide-eyed look. So this is after idurfonium. So mind you, the time frame after they give it, 5 seconds. So they'll know very quickly in clinic, just based on the presentation, if the person is a positive response to idurfonium. It's pretty good. Idurfonium tends to catch, I think the vast majority of cases, I want to say upwards of 80%. So it's pretty effective as a screener. However, because this is a muscular weakness condition, we do have a red flag issue, and that's called a myasthenic crisis. So the issue here is to the peripheral nerves taking care of breathing. So they can get weak to the point where the person cannot handle breathing on their own and they need mechanical support like a vent. So it turns out about 1 in 5 of your patients with myasthenia gravis will have one myasthenic crisis. I think almost every single one of the patients I've had in an inpatient setting with MG had a myasthenic crisis, or they had myasthenia gravis and they had another diagnosis. Always, for me, the ones I saw, pneumonia. So those two things in combination are pretty rough for these folks. A new diagnosis is really hard to get under control, and so the majority of your myasthenia gravis or your myasthenic crisis patients are early in the course of the diagnosis. They're still kind of figuring out how to manage their energy, how to prevent flares. Sometimes they get a warning sign. This is called a myasthenic flare, in which it gets worse. And this means they need to go see their physician to prevent a possible myasthenic crisis, which will land them in the hospital. So these folks need to call their neurologist and get in to see if there's management that needs to occur. Signs and symptoms of a myasthenic flare tend to include double vision, slurred speech, weakness particularly to the upper extremities, issues with walking and falling, and difficulty swallowing. Basically, they will show the symptoms of their condition worse than they do typically. So this more or less is a yellow flag that they need to go see their neurologist for additional management, probably medication management. By the time they get to the hospital, if we hit all the way into myasthenic crisis, they're going to have to reduce the immune system's activity, and they'll do plasma exchange or IVIG if it's more severe. How does this go? Actually, it does not affect your life expectancy. It's just hard at the beginning as you're trying to get it under control. Once the person achieves better management, it goes really well, actually. So they have a pretty good quality of life. Some cases go into remission. For reasons science doesn't fully understand, if they have their thymus removed, half of cases go into full remission and the condition is gone. It used to be that they would take the thymus out from an open chest surgery and you'd see those scars. Anytime I see those really thin ones, I think, okay, did you have open heart surgery or is that a thymectomy? Now they can go in and do these smaller scoping type procedures and go in with these smaller motions to come in and get it. Okay, let's go ahead and stop here and we'll move over to the next diagnosis in part 2.